appreciate that. So Dr. Sharman, Dr. Kinney, we see you live. Can you hear us?
Very well, and we are ready because I know with excellent educational lectures. The first case really was, I would say, the start of the show. Now we have another case, and of course, Howard Herman's presentation, and this case will be the appropriate for his. That is smart trial with you, Roxana and Howard, and hopefully he's there. We'll need a lot of help and
he's here.
What to do.
Waiting to see what kind of case
Okay,
you're
let's
putting
show
in
the
his
slide.
trial.
That's it, right here. 85-year-old patient, classical symptoms, of course, had a cabbage, multiple PCIs, and good medical therapy, and has a severe aortic stenosis, high gradient, and we'll ask a stem.
Yes.
Just to once again, we welcome everybody from the cath lab. Last time I didn't say cath lab of Mount Sinai for this, our New York Valve Symposium. So now we have Stem talk about the echo finding live. Let's show the echo, please.
Yes, good morning again from Mount Sinai. This is a parasternal long axis view of the left ventricle. The ejection fraction is about 40 to 45%, and you will see more in other views. As you can see, the aortic valve severely thickened, calcified with decreased motion. And this is a zoom-in view again of the aortic valve, decreased motion and calcified. Mild aortic regurgitation. Short axis view, trileaflet aortic valve, thickened, calcified with again mild aortic regurgitation. This is a four-chamber view. You can appreciate the distal septal apical septum hypokinesis because of the history of myocardial infarction in this patient. Ejection fraction is again 40 to 45%, normal RV function. PA pressure is about 30 to 35 millimeters mercury. This three-chamber view of the aortic valve, again thickened, calcified with mild aortic regurgitation. As you can see here, the maximal velocity we got is 2.8. I should say that in the screening echo that we did yesterday, on the right parasternal view, we got almost 3.7 to 3.8. We cannot do the right parasternal view here in the cath lab because of the position of the patient. But anyway, the mean gradient was 17 here. And with continuity equation, aortic valve area severe 0.6 centimeters square. And stroke volume index 18. So it's the grade is low flow aortic stenosis. The gradient today is low because of the view. So you can say that it's a low flow, low gradient aortic stenosis because of low ejection fraction. And this is a subcostal image with no evidence of pericardial effusion. Thank you.
Beautiful. Okay, let's go to the slide, our continuation. So clearly patient has a severe aortic stenosis, question about the gradient. And this is here the CTA, Gilbert.
Yeah, this measurement is actually a little bit off. Actually, we've got to remeasure the annular area. It's actually less than 430. It was around 429 millimeters squared. LVOT is a little bit smaller. Next slide. And you can see that the STJ and the sinuses are pretty large for either prosthesis. Next slide.
So now, no, actually here, I wanted to just pause here. So from Howard, that this case could be the case for your small annulus smart trial?
Yeah, thank you so much for thinking about enrolling, or did you, I guess you did enroll in the trial for this patient. It is a good example of a small annulus patient, and most importantly, suitable for either device. That's really the key. It has to be a patient who can get either device, has adequate sinus room for Evolute, has adequate STJs for Sapien, that there's not severe LV outflow tract calcium, and has transfemoral access. So this is a good patient.
Well,
it
what
also
about the coronary heights? Could you,
Right.
you want to comment on that?
Next slide.
I'd also just point
you can
out
see there
this is an example of the problem with gradients. So here in the hybrid operating room, you have a gradient that's close to half of what you measured as an outpatient, 17 instead of 30 something. And it just shows the effects of low flow, supine, not getting an adequate angle on the transducer, and why gradients in the room are often not as reliable as at other times.
Oh, yeah, thank you for that comment. That's really very, very important. Do you want to talk about the coronary heights as well, and what makes it to our trial, Howie?
Well, there aren't any, real exclusions for coronary height, except that you feel comfortable treating the patient with either device. So when the coronary heights are less than 10,
Exactly.
we ask you to examine that carefully and make sure the sinuses are large enough and that you're comfortable with both devices. So that's a trigger point. It's not an exclusion, but it's a consideration.
Thank you for that.
Beautiful.
Okay, Dr. Sharma, is
Okay,
that
so
okay?
good heights in this case. Yep. Yep. And the femoral access, actually, Parashuram is our associate director of the structural heart interventional program here, and very much actively involved in all our structural cases with Sahil Hera, who just gave the beautiful lecture. He's the director of interventional director of the program here. And Parashuram, tell us about the vascular access point of view.
Sure. Thank you, Dr. Sharma. So from our TAVR CTA pre-planning, we know that the patient had mild to moderate calcified peripheral arterial disease. We chose the right side as the site for the main access in the big sheath because the left, as you can see from the CT, the left common femoral artery, especially at the mid-femoral, had a significant calcium. And even for the non-main access, we had to use ultrasound and go higher than that. And one other caveat about the right side is there's actually a focal spot of calcified lesion at the junction of left external iliac and right common iliac and right external iliac. So, and that's actually even seen on this.
Okay, go on fluoro, please.
Fluoro.
Yeah.
Show us the fluoro. Yep.
Good.
Thank you.
Yeah. Right there.
1 minus. Yeah. So this is the subtraction angiogram of the right side, and you can see at the junction of the right
Yeah, we
external
see it.
iliac and right common iliac, there's a calcified lesion. So we actually got access, and this is the right common femoral artery, which actually looks okay. And after we obtain access, we put in a 10 French short sheath. We used the 2 Proglides, and we used a 1-to-1 sizing balloon, which is a 7040 semi-compliant balloon. And we actually went nominal pressures there. And and this is the angiogram post-ballooning. It looks like we achieved definitely some lumen gain
Did you think
with
you
no
needed
residual dissection.
lithotripsy, like using
Sure.
shockwave?
Shockwave. Yeah, great question, Dr. Mehran. But the calcium on the CTA was actually not more than 2 quadrants. It was just on only 1 quadrant, and the lumen was actually only on one view. It was 4.5 centimeter by 7.3 centimeter. So it looks like an eccentric lesion and also less than 2 quadrant calcium. So that's why we thought that this lesion will be compliant to a semi-compliant balloon. And our plan was if this lesion did not yield with this, then we'll go ahead and do the shockwave. But it looks like it went.
Yeah,
it did
it
yield, and
looks
then
good.
our dilator went well, and the sheath also went okay.
Okay, and then you did a sentinel also?
Yeah, we did a sentinel, so it was a little tortuous in Omnate, but we were able to deploy the sentinel device, and yeah.
Yeah. And just coming back to the point, I know this will be a lot of discussion, maybe some questions by our audience, that when do we use sentinel? So we clearly have seen, and I know that publications on that issue, that once you use routinely, your CVA rate goes down. And that is what we do. It's like a default approach. If we don't use sentinel, we document in our cath report why the sentinel was not used, whether excess, tortuosity, absent radial pulse, whatever the reason is, but it's documented. And therefore, our focus is that use sentinel as much as possible. There is, as I said, that a lot of people are concerned, maybe some cases no benefit, but clearly what we have seen, yes, it decreased overall CVA incidence. More importantly, the CVA which occurs, it's smaller in magnitude. That is what we have noted at our center. Anube,
Yeah, it's great to,
comment on
as
it.
you're
And we
as
want
you're
to say
going, can we get a comment from our audience, from our wonderful panel? I mean, Eberhard Grube was part of the very original Sentinel device. Raj Makar was one of the major investigators. I'd like to hear, is that your feeling as well, Eberhard? Are you using it in all cases?
I think he pointed that out very appropriately, and I think you're looking at the calcium. I think that's one of the cases where I would also go, even if you go selectively, and not on everyone. I'm a protagonist for using it on every patient, but here this is something that I would definitely support, Dr. Sharma. That a lot of calcium, and I think that's a very good idea.
Raj?
So, we use Sentinel consecutively in almost 1,800 patients, because when it was first approved, and our belief was there is enough evidence to use it till there is evidence that we shouldn't use it. And then, of course, we did the TVT analysis, and there was no convincing reduction in stroke rates. We did see maybe a little bit of hint towards reduction in major strokes. We then adopted the approach of enrolling all our patients in the randomized clinical trial in the protected TAVR study. So that's what we are actually doing right now.
Yeah, and we're watching Dr. Kinney perform her balloon valvuloplasty. Is that right? Maybe we can.
Yeah.
Yeah.
Can you tell us what
Yeah,
size
small balloon.
balloon? Because this seems to be moving.
20.
up
That
and
was a
down.
20.
Yeah, that was
Yeah.
too small. Okay.
Too small.
So while they're finishing, okay, let's keep going with the slides now.
Yeah,
So let's
next
complete and then
slide.
we come
Yeah.
back to the point. Yeah. So femoral access we've spoken about, sentinel we talked about, and this is the crux of the case.
Can you help?
Basically, patient was high STS risk score. Now, a smart trial. So Howard, as you know that, I'm sure you may know the results, but maybe I'll ask. So this is an ideal case. Now of course, the trial is ongoing and we are, I think, 5th or 6th in the country to randomize patients in the SMART trial overall.
Going.
And question is Evolute versus Sapien, and of course, central device, which we have done. So any guess what this patient was randomized actually? There was initial question, but then everything was approved. Then we randomized the patient on the table. Today, we have 3 TAVR cases. First case we already did with the Sapien. The third case with the bicuspid valve, which is case number 4, is with the Evolute. And this one was a tie. Whatever it comes out to be and the randomization, and then we have one mitral clip. Any guess what this patient was randomized to?
It's a 50-50
It's
chance,
a 50.
right?
Yeah, I don't
So-
gamble
But I
unless
want
the
to know
odds
now
We're
are.
is
not
the phase
gambling.
two,
The
no
odds are
50%.
not,
Now it's
Yeah, I don't gamble
100%.
unless the odds are in my favor. So I'm not
Yeah.
gambling here, and I
Okay.
have no.
I just
knowledge about
saw the
this.
delivery
This is-
system. I'm going to
We
guess
just saw
Edwards.
it too, yeah.
Yeah.
Why don't you guess, David, since you saw the delivery system?
I just saw it. That was perfect.
Yes, it has been randomized to the Sapien, and we are using a 23 millimeter plus 1 cc, our Sapien valve.
Okay.
One of the key elements of the trial
wire?
is
Pin the
that
wire?
we have a number,
the
we have
wire?
over 70 sites activated of the 90 that are going to be in the
The
trial.
wire?
And some of them are sites that were primarily experienced in Sapien, some were primarily experienced in
Watch your feet.
Evolute. So we're trying very hard to make sure the techniques are similar
he's
at all these
rewiring the
hospitals
pickup.
with both devices. So we have a checklist for both Sapien and for Evolute to make sure that all standard operating procedures or procedural aspects are being performed, including checking the height, the depth of valve implantation in a cusp overlap view, not
hemo-
only for
invasive hemo
Evolute,
after.
but also for Sapien.
Yeah.
Beautiful.
Yeah, so here we're going to do 23 plus 1 because we're slightly undersized. As you saw, the annular area is a little closer to 430, the upper range of the trial.
So what do you think the time enrollment, you think that it will finish enrollment? End of next year, mid next year? What do you think?
We're
Yeah.
aiming for
Yeah.
end of 2022, end of next year.
Yeah, we're pushing. I mean,
Yeah,
not
beautiful.
all of the sites are as active as you guys, and I know that I push Mount Sinai a lot, and as you see, every one of our small annulus patients are being evaluated for this trial, and we urge the investigators who are here and the ones who are online to do the same so we can get this work done. And I think it's a really important trial.
Roxana is
tell
the co-investigator of the trial, and if we don't make the deadline, I'm gonna make it up to her to make sure that we get good enthusiasm and enrollment.
Yeah, that's right. That's right. Well, thank you. So here we are. You want to tell us? I saw a little difficulty, but you know, Dr. Kinney is very strong. She works out a lot, and I see that she's pushing with no problem at all. But tell us, what is it feeling like? Are you having some difficulty there?
No, we did have some difficulty even removing the BAV balloon,
Yeah.
and this is usual. This is usual
So
for Sapien valve.
can I
but
ask why
nothing unusual.
whether you pre-dilate on every patient or why you pre-dilated on this patient?
Why?
Well, we like to pre-dilate here, at least Mount Sinai, because we know that from the literature, at least there's less post-dilatation. And we feel that with pre-dilatation, condition the valve a little bit to, number one, minimize the hemodynamic interference. You know, when you cross the valve, you might actually cause outflow obstruction, and the pressure might go down, so you don't have a lot of luxury to position the valve and deploy. And second, we think that the valve expansion might be better, especially particularly in these small annuli patients. And we've seen that even if you post-dilate with nominal volume, you actually have an expansion of the stent frame. So because of that, I think we prefer the pre-dilate, particularly more calcified valve, like in this one, as you saw in the CT.
180.
Wait,
Did
can
a
you just
Saibal
tell
arrive
us
yet
a
or
little
no?
bit? You feel good about the position? Are you using echo?
we are doing
No,
it now.
not
No,
yet.
no,
We're
no,
doing
no.
it right now. Don't keep quiet.
No, I know, but the picture is
Remember
at the
what we
bottom.
do? We go with the pace speed
going.
and then
180.
take an injection, not deploy yet, and then decide whether right position, which we are then going to do it now. Good.
I think you have to go in a little bit
Stop.
more.
We're going to pull back.
Off,
Stop. Facing.
off, facing. Good.
Enough,
There's
enough.
good view or no?
No, this is 27, cranial
show the
18.
hemodynamic, yeah.
Good.
I think we're good now.
So let me ask you, is the Saibal
That's better,
right
that's better,
there yet
good.
or
Yeah,
no?
Saibal is
Okay,
here.
we are
Saibal,
ready
any
to go up.
comments?
Oh, good. So no, but
Can you
question is,
give-
I'm sure he
180.
will not pre-dilate
Can
this.
you
I
give him
mean,
a
I know a lot
microphone,
of
please?
people are against pre-dilatation.
180.
Saibal?
I was a little surprised about the pre-dilatation. I mean, I take patients which have heavily calcified valves,
Sit in.
and if the gradients are greater than 40, I pre-dilate, but all of them I don't pre-dilate.
Yeah.
You stop the pacing
All right.
now?
Facing.
Off, facing.
Yeah.
Resuscitate.
Valve position looked good. It looks
Okay.
like you.
Okay, let's bring it down. Let's look at the angiogram.
1 second. Okay, let's wait for some.
Okay.
Okay. Yeah,
Let's get the hemodynamics better in order.
Perfect. Okay, good.
You want to do a quick echo?
No, yeah, and then
Before
we
you
need
take
to
the
exchange
wire
the pigtail. No, we need to exchange the pigtail.
Yeah.
So let's do that first.
1 second. Wait, 1 second. We're taking out the
System.
system.
Hold the sheath.
These procedures are looking as easy as you would like them, right, Alan?
I'm sure that
You
is.
are?
Alan is
would
here. I
probably
wanted to.
also-
Well,
that.
actually,
Yeah.
it's an excellent procedure, very well done. And the only question is about the pre-dilatation, because pre-dilating also you have to explain which balloon size you use for pre-dilatation. Do you want to crack the calcium? Then you have to have a big size. You want to facilitate
Bring the echo on the screen, please.
to facilitate the entry
take a piece.
inside the
Yeah.
aortic valve, which is more or less
No, wait.
useful. So.
Where's
I
the
think
other
if we
way?
pre-dilate, one of the interests would be to do an angio at the same time and to do a kind of balloon sizing when you hesitate in the final size of your valve.
So you often don't pre-dilate. It sounds like the team here on this table
Okay,
are not really
Yes, yeah.
pro pre-dilatation all the time. Anyone else have any comments?
I know. I also know the Raj. Raj also does not pre-dilate. We have done many meetings together live. He also is against. I know I have published quite a bit also that no
Yeah.
pre-dilatation.
Zero.
Yeah, also,
Yeah,
especially in this
minimal
case, since
PVL.
the annulus was a
Figure,
little bit
figure.
large and you were using 1 extra cc, that would be yet another reason for
This is
me
also-
not to pre-dilate. But for bicuspids and heavily calcified valves and horizontal aortas, I think that's where I pre-dilate.
Can you show the hemo?
Okay, take that, please.
Yeah, and also the
Okay, let's see the
hemodynamics
stem
and the
and the team. How is the
findings,
echo?
please.
Yeah, echo is okay, yeah.
Yeah.
Echo looks good. Good position. Let's measure the velocity. Minimal AI, minimal. If at all, okay, let's put the velocity, please. Continuous Doppler, yeah.
Well, often we always ask for the lecturers to shorten their lectures to make up time. We never ask for the live cases to shorten the time. And here you guys are performing the procedures in such a timely, wonderful
So
fashion. I
it's
can't,
Great, yeah.
I
Yeah,
can't,
looks normal.
I can't
Nothing.
congratulate you
Minimal
guys
PVL,
enough.
Normal velocity, yeah.
Right.
Well, we need to catch up. Actually, only one person I did not introduce. Can we show our the tallest guy in this room? Farhan, on the picture wise, he's used to be attending. Now the structural fellow will be attending soon. He cannot even come in the camera. We had to go the Zoom.
That's good. You have, that's great. But I wanted to make sure that we got everyone to comment on this. And David, you're on here, and you saw all of the stents there in the patient, but those were old stents, I know. Any comments? Anything to add? Do you pre-dilate? Do you use neuroprotection? Is this exactly how you would have proceeded?
So first off, I think this is a great case, and congratulations to the team for enrolling a patient in a prospective study as part of the live case. I think
That's
that
right. We
needs to
can't
be
wait to get
acknowledged.
started with complete TAVR, that's for sure.
Absolutely. And then, yeah, I must say, John and I, maybe I'm older, like I need to grow my gray beard back. But yeah, we do not use cerebral protection in all patients, and we very selectively pre-dilate.
All
But a
right,
great
well,
case, fabulous
Excellent case.
Okay.
Any other final comments,
All right,
Dr.
Roxana,
Sharma?
if that is, yep, fine. No, ask if any of the panel wants to. Otherwise, at 12:15, we can have an early lunch, and then
Yeah.
we
No, we
meet
wanted
at
to-
1 o'clock after 45
We
minutes.
actually wanted to have exactly this time. You really made this up. The lunch was supposed to start at 12, so now we make up time. And we ask everyone to go and get lunch and be back here for live case number 3, where Dr. Stone will moderate with you a functional MR transcatheter, a TER, with you. Okay? Thank you, Dr. Sharma
At
and
1
team.
o'clock.
Thank you very much.
See,
Lunch
everybody at
until
1 o'clock.
12:45.
Exactly at 1.